Hi everyone, Dr. D over here. Today in Dynamic Talks, I have board-certified gastroenterologist Dr. Zaid Rana. Welcome in.
Thank you for having me today. It's a pleasure to be here. I know you and I had a long conversation about obesity and with psych component, so I'm happy to have this talk.
Yes, so today we're going to be talking about obesity and depression. So how much one leads to the other and the other leads to obesity. So we're going to dive right in. How often do patients with obesity also report significant depressive symptoms, and how do you approach that comorbidity?
Awesome question. I find that even though they may not mention they have underlying depression, because sometimes it's not diagnosed, not everyone wants to go see a psychiatrist or a psychologist to understand that aspect. We do a good job with pre-op side of things to understand what is the psychosocial component, because we do know there's a very strong component that's going to play into your weight loss and your obesity thereafter. So if that's not addressed, then unfortunately you may not get the results, or you may end up with worsening results.
Right. So you personally, how do you manage that in your practice? Like, how, do you screen your patients? Do your patients speak to, I think you're mentioning earlier that you have a psychologist as part of your team?
So part of our team, the nice thing is that when you come in for that consult, that initial consult, when our ARMP sees you, we go through a whole screening process. And that screening process is going to entail any sort of depression symptoms that you may be experiencing, or if you're already on medications, because that's going to tell us, hey, do we need to get you to a clinical psychologist, or do we feel like there's something triggering that we need to get a pre-evaluation before we even continue doing any sort of surgery or procedure for weight loss.
How often do you require your patients to get a clinical evaluation to rule out, to make sure that they're stable, that they know what they're getting themselves into and what the post-op care entails, right?
So we pretty much do that with all our patients. I'm sure there's some exceptions out there, but we pretty much do try to keep a standard if you want to get all patients screened in that regard, because we know it plays such a huge role thereafter. So in my kind of practice for weight loss and my general GI, I do get a big bulk of IBS patients. And most times when they're coming in with any sort of GI complaints, a part of the puzzle is figuring out, is there an IBS or a gut-brain component here? Or is this maybe just truly reflux that just needs to be treated? So I tend to ask a lot of those type of questions in my general GI practice, because we know that, and I'm sure you know just as well, as if there is a strong psych component or depression component, it can manifest as a gut component. So if we're not treating one, then you feel like, okay, I may be healing one, but then I have problems in the other. So it's a very strong balance between the two.
You know, funny that you say that, because I always said that the brain and the gut are interconnected, right? And that's probably why there's a lot of serotonin in the brain, but also in the gut. So that's why when you start taking SSRIs, what you first feel is what? GI symptoms, right?
Exactly.
Because there's a lot of serotonin receptors in your gut, right? In the gastrointestinal area. So I always say that's why when we talk about, oh, I have butterflies in my stomach, what does that really mean, right? It means that you're having a lot of GI, I guess, movements, activity, right? Because it's interconnected with your brain.
Absolutely. Absolutely. I would say, I think like 80 to 90% of your serotonin lives in the gut. So if that's dysregulated, imagine how the brain's dysregulation is going to look like. So if you can stabilize one, then often it will help with the other two.
Right. Should we screen all patients with obesity for psych issues, even if they're not surgical candidates?
Yes, 100%. Why? Because maybe you're not a surgical candidate, but the obesity is stemming from your habits, like the depression that may be occurring. If we can help that underlying issue, then you may also start having the weight loss, and that in turn is going to help you feel better as yourself, and that's going to help the depression. So it's not enough to fix one. If you fix one, but you can also help the other, then I think they're going to go mutually and help aid each other.
And it's like you were mentioning before, we're talking about IBS, right? Especially IBS that we know that is like interconnected with anxiety and depression. So yes, you treat the IBS, the gut symptoms, but if we don't fix the underlying anxiety, right, or the underlying depression, it's like we're back to square one, right?
Exactly.
Are the symptoms are really going to be gone, or we're just like putting a Band-Aid over it?
And a lot of times, like you said, it's a Band-Aid that you're putting over it. So if you're not fixing the underlying problem, then that eventually is going to manifest down the road. Maybe not in the first 6 months, but eventually it will happen.
Right. And tell me a little bit of like, how do you manage IBS in your practice?
From even our GI recommendations, a lot of times it depends on what kind of IBS you have. And we have IBS, constipation, diarrhea, the mix on the unspecified. But then you also have things that could be epigastric distress syndrome, which may not be on the typical IBS umbrella, but a lot of times manifests from a gut-brain interaction. So I find initially, depending on what their symptoms may be coming for, I may go with the minimally, maybe like a pantoprazole to see if the reflux is related to that. But if they keep coming back and there's no improvement, that's when we start thinking, okay, we have a whole criteria that can just diagnose IBS. And that's where sometimes I'll stem with starting with like a TCA or an SSRI. Or, you know what, I'll talk to their psychiatrist if they're already on something. Maybe there's an alternative choice that we can use if they're using, let's say, an SNRI. Is it possible we could switch over to something that has a little bit of better relief for both the gut and brain?
Right. Or sometimes even put them on a low dose of a TCA if they're already like well managed for the underlying psych on an SSRI and still there's no relief, right, from the IBS.
But I think that's where having that your healthcare provider kind of being involved, that you guys can communicate with one another to make the best option for the patient.
Right. How do you give somebody a diagnosis of IBS? Because it's a rule out diagnosis or
not anymore. So interestingly enough, I would say about maybe 2 years ago, 3 years ago, the ACG and the AGA came out with specific criteria for IBS from what we call it the Rome 4 criteria, that you can diagnose them right off the bat without having to go through, like you said, the diagnosis of exclusion.
Okay.
So a lot of times it depends on the kind of type that they may have, and that's why IBS is so tricky, because you have 4 types and not everyone falls into the classical type. And I'm sure even in the psych world, not everyone falls into a classical diagnosis. So it sometimes does become a bit of a trial and error, but you don't have to wait to try all these other things first to call this IBS. But within the IBS, it may be a little bit of a trial and error to figure out what works best for that patient.
Yeah. And I mentioned that because I do have patients with IBS and also anxiety or depression, but sometimes I don't know what type of IBS they have. They just say, oh, I was just told IBS. And I guess maybe because the gastroenterologist doesn't know what type of IBS they have.
It's possible. Or, you know, I think sometimes you have to delve a little bit deeper and find out, let's say in a month's time, what is the predominant? Would you say I have more of these symptoms or these symptoms? And if they say, well, it's 50-50, then okay, maybe it is the mixed type. Or maybe they can't put a finger on it, it's the unspecified type. But more than likely, if you can get down to their diet to figure out what's triggering you, like what are your bads, then you can often figure out which would you predominate.
How do antidepressants affect GI motility or symptoms like constipation, especially in obese patients?
Now, when we talk about obese patients, I'm going to also delve into like if your sugar runs high. We know once they're above 180, your sugar, your gut's going to have some dysmotility to begin with. Maybe you're not fully diabetic, maybe you're impairing hyperglycemia, but it will impair your gut. Now, when you use the SSRIs and you're having, let's say, a lot of bloating, epigastric pain symptoms, the SSRI may actually modulate those symptoms so that you actually feel improved or better. But the constipation part of it, if it's an IBS predominant versus a chronic constipation, it likely will also help with that as well. Sometimes we may have to use a little laxative to help you go initially while the SSRI kind of kicks in, because we know it takes about 6 weeks for it to actually have efficacy. So you may need something in between that. But then you have the flip side of, let's say, they suffer from diarrhea. You know, I actually always remember this one patient who was passed away. And the patient mentioned me, she's going like 10, 12 times a day, which was never like that before. We got her on amitriptyline low dose, and I would tell you within a month, she was back to having regular bowel movements. So it really depends on where's your predominant symptom and what is going to be the best drug for you.
Patient specific. Yeah. Get to know your patient.
Hey, 100%. And I think the same in the psych world, it's very similar. If you don't know your patient, yeah, there's thousands of drugs out there, but which is the best for that patient?
Exactly. It's like, it's not one size fits all. It's like, get to know your patient, their background, right? What their diet is like, what do they do, how's their lifestyle is, and then you try to pick medication that you think is going to help them.
And I think another component of this that sometimes we as physicians tend to forget is their background. Not all people are the same. If they're, you know, Haitian, or they Latin, or they Pakistani Indian, or the South Asian, I think it plays a huge role because their diet is so different. So different.
Especially in Miami, where just like it's so multiculturally and there's like so diverse and there's so many different patient even if you're Latin, there are so many different Latins. It's like not everybody has the same diet, right?
Exactly. And that plays a huge part from my end, because once they go through, like, let's say the endoscopic sleep procedure, I have to consider, okay, your diet is a big part of who you are. So I have to also figure out, okay, I can't tell you, hey, you can never eat this thing that you've eaten all your whole life, but it's trying to figure out that balance. How can I fit this portion as part of it, or put it back into your life again?
What is your take on the use of SSRIs or SNRIs in patients with obesity and functional GI disorders? Do they help, harm, or both?
So I actually am inclined to agree that they likely help, especially on the functional side of things, like functional dyspepsia. Because we know there's, again, a very strong gut-brain interaction.
Okay, tell us what functional dyspepsia is for a lot of people who are watching and have no idea what that means.
So dyspepsia by itself, so a lot of times that pain that you kind of get underneath your breast line, it could be related to reflux, or there's a non-reflux component. So let's say you've done all the testing, you've ruled out that it's not reflux related. A lot of times that gets then termed functional dyspepsia because there's not an underlying cause, either gastritis, inflammation, or H. pylori that's causing this. So it gets labeled as functional dyspepsia. And a lot of times now we know, okay, that's more of a gut-brain interaction. And a lot of this keeps going back to that same theory of gut-brain interaction. So that's where the SSRIs, the SNRIs, the TCAs really help, because if you can modulate that brain portion, it'll kind of manifest and heal the gut component as well.
It's kind of like what I tell my patient is like, if we can relax your brain, your gut is going to be relaxed. But if you're always in hyper alert, what do you think your gut is going to be on? Hyper alert. It's going to be tense. You're going to have the sense of impending doom. You're going to have all this like GI motility, right? It's like whether it's diarrhea, constipation, or a combination. But it's just like, let's relax your brain so your gut can be relaxed.
Exactly. And if you don't sleep well at night, it's going to manifest in so many other ways as well. People often don't think about the hydrational aspect, the sleep aspect, because it's such a strong component with everything else.
Why is a psych eval required before a gastric bypass surgery?
So it's one of the most invasive surgeries that are available. Well, I myself am not a surgeon, but we have our data that came out in 2007, 2012 that showed that a lot of these patients, years down the line after a gastric bypass, may start manifesting more of their depressive symptoms. Maybe if they suffer from before, may worsen now. And imagine you just connected pretty much a very small portion of your stomach straight to the small intestine, where you don't have that reservoir or that tank anymore. So all that the hormones that are coming from the gut now are pretty much not there. Your small intestine is doing much more of the work. So your absorption changes. That's why they're on vitamins and iron for the rest of their life as well. So it has to manifest and affect other things as well if we're not having the same level of absorption. We just talked about how serotonin is found so rampantly in the gut. Now, if I'm altering all that, we want to know beforehand, is this patient at risk of developing other habits down the road? We know that, as we were talking about earlier, the addiction exchange that can happen, usually we see about 1 to 2 years down the road. So we want to target these patients early on to know, how can we manage you thereafter? Because the most important, anyone can do a surgery. The most important part of this is all the things that come thereafter, the nutritional, the psychosocial. And if you don't feel happy with yourself, then it's going to manifest in your brain and your gut.
And tell me, is this clearance a one-time clearance, or every single time that you're going to get, let's say you're going to have a follow-up procedure because maybe you didn't lose all the pounds that you needed, or there was some sort of complication, you need to have a second surgery, do you need a clearance again?
So usually it's a one-time clearance. There's no strict guidelines to this. However, if you ask me as a personal opinion, I wouldn't use the word clearance, but I think that there should always be mile markers that you're checking in with these patients to see, okay, how is not just your weight loss, but your well-being. We need to also make patients understand that you need to develop a healthy relationship with your scale, because a lot of people get fixated on a number. Oh my God, I lost 1. I put on 1. But it fluctuates. You may fluctuate 3 to 5 pounds every day. If you didn't have a good bowel movement, that's going to affect you. But a lot of people get so fixated on a number, and that in turn then affects the brain, which then will also affect the gut. And then you could develop that vicious habit where, okay, I'm not losing weight, I'm going to go back to eating. Or vice versa, I might just start starving myself, which is not the things you want to do when you're trying to lose weight.
Exactly. We were talking earlier that there's obviously a very strong relationship with eating disorders and patients looking for a gastric bypass, especially in bulimic patients, especially in binge eating disorder, especially in nighttime eating.
Yes.
Right? There's a lot of data about those 3 disorders in specific because they get obsessed with weight.
Correct.
With the number.
Yeah, they fixate, and then for them, it develops that same vicious cycle that happened even before they did the surgery, but then often worsens it thereafter because they think, oh, well, I got a surgery, I should be losing weight. And then if you're not getting to where you want because you haven't fixed, let's say, the brain aspect of things, then it's just back and forth.
Right. So question, if there's a patient who is struggling with eating disorder, right, and you do a psych clearance and you find, that they're not clear, what's the follow-up? How do patients follow up? Because sometimes patients is like, well, I'm not clear. I'm not going to clear forever. I'm never going to be a candidate. And they get like depressed or hopeless. Like, oh, I really wanted to, like, what's the step afterwards? Like, let's say you get a patient who, I don't know if that ever happened to you, but if you get a patient who's not a candidate at this time because there's an underlying, psych condition, there's an underlying addiction, there's an underlying eating disorder, there's an underlying mood disorder. What's the follow-up?
So at least from my end, it's a lot of times getting them to a healthcare professional that can address that issue. And then we try to get them what's called stability. And I don't mean a week. I mean, you may need 3 to 6 months to develop that stability first. And then we'll communicate with your healthcare professional to figure out, hey, are they at a point where you feel that they will be able to tolerate the surgery without going through the vicious cycle? And then it's going to be a lot of following up with us and their healthcare professional, whoever is managing that portion of it, because it's not just a one size fits all. We know that each person, each patient is so different that, let's say after the procedure, they lost 15 pounds. Now they're feeling good about themselves. But then that following week, they hit a plateau. Well, that's where we start to worry, like, okay, are you going to go back to that same habit? So that's why it's very important that they're following up with everybody that's part of that process.
Right. They have like a multidisciplinary team in place.
Exactly.
Right. Like they have good social support, family, friends. That's also important in the post-op care, right?
Yeah.
But also they have different providers, like they can assist, like in nutrition and diet, like a healthy diet habit.
Exactly. And then even on the addiction aspect, you want to make sure they're not still around the same people that may be forcing that addiction to get worse or kind of causing them to be addicted. It's a large process, not just any one thing, do a procedure and move on.